The RSI Checklist. Why do we use checklists? To improve accuracy and reduce mistakes during high-stress medication administration and procedures. And during RSI in particular, it increases our chance for the first attempt success. This is the checklist. Resuscitate before you intubate. Use the Heaven criteria. Make sure you are using your PPE. Evaluate for physiologic issues using Lemon and Moans. Align your axes. Select your induction agent or muscle relaxant. Decide on your agent. Dose your agent and draw your agent. Decide on your paralytic. Decide on your agent. Dose your agent and draw your agent. And then select your post-intubation medications. Decide on your agent, dose your agent, and draw your agent. Make sure you have push-dose pressors standing by. Again, decide on your agent, dose your agent, and draw your agent. And then always have a failed airway plan and evaluate for a cric. Next step is to make sure the patient is pre-oxygenated, whether that is with a non-rebreather, CPAP, or a BVM. Make sure they have a nasal cannula at 15 liters per minute on, and remember, that is a regular nasal cannula, not an end-tidal nasal cannula. We use that for nitrogen washout. Make sure your patient is positioned correctly. Make sure you have adequate vascular access. Make sure you have all of your equipment laid out. So you want your bag valve mask, preferably with PEEP. You always want a bougie standing by. An endotracheal tube plus or minus one size, a 10 ml syringe, your capnography, your backup airway, an end-tidal tube holder which is preloaded behind the patient, a laryngoscope blade plus or minus one size, and an extra handle, whether that's a video laryngoscope or a backup handle. Make sure you have your suction ready and present at the patient. Next, we are going to administer induction, administer the paralytic. Once the patient is relaxed, we are going to lead with suction. Then we are going to perform the intubation. We are going to confirm, first with direct visualization, then with end-tidal CO2, then with breath sounds and no epigastric sounds. Then we are going to secure the airway, and then we are going to document. So some pearls. The first big thing we need to think about is to resuscitate before we intubate. If the patient needs fluids, push-dose pressors, or to be started on vasopressors before we intubate them, we need to make sure it's done. If the blood pressure is borderline, start the pressor. Your medications are going to drop the pressure, and just the procedure could cause the patient to go into cardiac arrest. So we want to make sure they are fully resuscitated before we intubate them. If the patient shows signs of tension pneumothorax, make sure a thoracostomy is performed before the intubation. Positive pressure will cause worsening of the pneumothorax and could cause a traumatic arrest. So again, we're going back to the checklist. So here are our Heaven criteria. Hypoxemia. So less than or equal to 93% at the time of initial laryngoscopy. So we want to try to get their pulse ox as high as possible, and that is with a good waveform. These are things, the Heaven criteria are things that could lead you to believe you're going to have a patient who could decompensate or have difficulty with the intubation. So hypoxemia, extremes of size, a pediatric patient less than 8 years of age or clinical obesity, anatomic challenges, trauma, airway masses, swelling, foreign bodies, or other structural abnormalities limiting laryngoscopic views. So you could have a small mouth or things like that, limited opening. Vomit, blood or other fluids, fluid present in the pharynx, hypopharynx at the time of laryngoscopy. Exsanguination, suspected anemia potentially accelerating desaturation during RSI-associated apnea. So that will just accelerate the rate at which this declines. And then neck, limited cervical range of motion due to immobilization or arthritis. So these are all things that could lead to complications with laryngoscopy. So then we move on to what are called Lemon and moans. So these are an assessment of the airway and a prediction of difficulty with intubation. So the Lemon rule is you look externally, see if there's anything you see which could cause a difficult airway. Is there a huge mass on the side of their neck? Evaluate. That is the 3-3-2 rule, which we will go over in a second. Then there's the Mallampati score, which we'll go over in a second. Is there an obstruction? Is there an internal mass? And neck mobility. Do we have spinal precautions, or is there arthritis or kyphosis? Moans. Are we going to have trouble getting a mask seal? Do they have a beard or a facial injury? Obesity or obstruction. So a body mass index greater than 26. Age greater than 55. No teeth or stiff lungs. Do they have pulmonary fibrosis? So here's our Mallampati score. So if you look at the airway, you see the hard palate, the soft palate, the uvula, and then you see the pillars. You've got a great view. That's class 1. You've got a great view of everything. Mallampati 2, you're starting to see the uvula disappear. You no longer see the pillars. Class 3, you almost completely lose the uvula, and you've got very little of the arches left. And then class 4, you don't see the uvula at all, and the arches are completely gone. So, the 3-3-2 rule. Now, the important thing to remember is when evaluating, you are using the patient's fingers, not your own fingers. Because the patient's fingers, if you have a smaller patient, their fingers are going to vary quite differently from my fingers. So, 3-finger mouth opening, 3-finger menton to hyoid, and then 2-finger floor of mouth to thyroid cartilage. And that is going to help you evaluate how anterior this patient is and how difficult it's going to be to intubate them, because how they're going to be able to open their mouth. This talks about aligning the access to get the best view on a patient based on how anterior they are. If you're trying to get a view on someone when they are like this, it's going to be very difficult because their larynx is very anterior. However, if you ramp them like this, you align all of the axes and you get a much better view of the vocal cords, even if the patient is anterior. In extremely morbidly obese patients, there is a technique called ramping. And what this does is it helps the tissue work with gravity, and it helps you intubate the patient easier. So you align the ear to the sternal notch in the same horizontal plane, and you put the patient's face parallel to the ceiling. So if you notice, the patient is ramped downward, but their face is parallel to the ceiling. And you can accomplish this with blankets, so again, going back to the checklist, we want to resuscitate before you intubate, follow the Heaven criteria, wear your PPE, be aware of physiologic issues, lemon and moans, align our axes. We want to choose our induction agents and our muscle relaxants. We want to decide on them, dose them, and draw them. We want to do the same thing with our paralytic agents, decide, dose, and draw. We want to do the same with our post-intubation medications, decide, dose, and draw. We need to do the same thing with our push-dose pressors. We always want to have them present at the bedside, decide, dose, and draw. We need to have a failed airway plan, and we need to have done a Crike evaluation. We need to pre-oxygenate well. We need to have a nasal cannula on 15 liters per minute and a regular nasal cannula, not an end-tidal cannula. We need to have our patient positioned appropriately, good vascular access, whether it be IV or IO. We need to have our equipment laid out, BVM preferably with PEEP, a bougie always, ETT plus or minus one size, 10 milliliter syringe, capnography always, a backup airway appropriate size for that patient, an endotracheal tube holder, which is already placed behind the patient's head, laryngoscope blade plus or minus one size, and an extra handle, whether that be a video laryngoscope or a regular laryngoscope handle. We have our suction ready to go. Then we go ahead and we administer the induction agent, administer the paralytic. We always lead with suction. We then intubate, confirm. We confirm first with direct visualization, then with end-tidal, then with positive breath sounds and no epigastric sounds. We secure our tube and we document. If you have any questions, as always, you can talk to me. Thank you.